Welcome to the Shreds of Evidence podcast, where we look at the evidence, or the lack of evidence, the policies and the politics that shape the way paramedics deliver care throughout California. This podcast is proudly brought to you by Stanford Emergency Medicine and the California Paramedic Foundation. My name is Marc Gautreau, and I'm the EMS Division Chief here at Stanford. In the studio with me, John Earhart, a flight paramedic and a director at the California Paramedic Foundation.
All right, so we're back in the Shreds of Evidence studio today. Today, it's just going to be myself, John Earhart, and Marc Gautreau, because Marc, you have some specific roles that you work in that will be very relevant to what we're discussing. And our topic today is APOD or APOT. So maybe, Marc, we could start there. What is it, APOT versus APOD? What does it mean?
Yeah, so APOT just is an acronym meaning ambulance patient offload time, and APOD is, well, the real problem is ambulance patient offload delays. And so what we're really talking about is the delays in getting patients from ambulance stretchers into the emergency department.
And when does a offload time become an offload delay? What's the threshold there? Is it when I have to wait when I'm not seamlessly, when I roll my gurney into an emergency department and I'm not able to immediately slide them to a bed? Is that when the delay starts, or is there some threshold?
Well, there is now a legal threshold. When AB 40 passed in October of 2023, it was signed by the governor, that sets the time at 30 minutes. Now, most of us who work in emergency departments or in EMS would say that 30 minutes is actually a little bit long for most patients. We should be able to get them off in 5 or 10 minutes, but giving the emergency departments the grace to find a stretcher, find a room, get it cleaned, and get the patient moved over is really what became, that 30-minute offload time. Is a negotiated point.
Yeah, I think if I was to look at it from a system operation lens, I've mostly worked in urban environments. So my, total call cycle might be an hour. So you're talking about a 50% reduction in system efficiency in an urban environment. If I'm working in a rural community, I did work in Fresno County for a little bit where we had some transports being a couple hours. Maybe it seems less impactful in a data sense that way, but that's a pretty big demand on EMS providers, right? To say you're going to incur automatically up to 50% or maybe even a little more, right? System inefficiency when things are busy.
That is absolutely true. And, each system is different, and each system has different expectations of the paramedics once they bring a patient into the emergency department. Some have the expectation that the paperwork will be done before they return to service. Certainly, you have to remake the stretcher, get your supplies back in order, things like that. But 30 minutes is certainly on the high side of a reasonable time to get an ambulance back in service.
So I have some questions for you around, because you have the perspective of both being a hospital provider that has to send patients up to floors, right? Get them admitted, do things. You're also a medical director for a very busy fire department, San Jose Fire Department. And you see the system operations side from a pre-hospital perspective. Maybe we just start there. We obviously know that the friction point or the point of discussion is in the transition from pre-hospital to hospital, the ability to release EMS providers back out to the 911 system, right? And for the hospital to safely assume care and have the staff and the resources to take that over. But what's the larger picture on this? What's the general patient flow, both pre-hospital, right? But you also have patients coming in by self-transport, walking into the ED. What are the sources? What's the throughput or the pathway? Where is it going? What's the ultimate bottleneck, right? Is it discharge from the IC, from the step down unit, or where's the ultimate gate?
So as with most problems, it's multifactorial. How did we get here? I mean, clearly there's been an enormous increase in emergency department visits over the past decade or so, more than a doubling. Likewise, there's been a great increase in use of 911 EMS for transportation. I remember when I first came to Stanford, we were in the process of planning construction on a new emergency department, which opened in 2019. It was under construction when I arrived. And even before it opened, we had to plan on reconfiguring the emergency department because the volume between the time of the planning of the building and the time we were going to open it had almost doubled. And so that's what resulted in us deciding not to move the pediatric emergency department into the new building and instead to construct a new pediatric emergency department in the footprint of the old ED and keep them separate. We simply didn't have the space to accommodate the huge rise in patient volume. I think we went from, when I first got there, we were just about to approach 70,000 patients a year. We're up around 120,000 patients a year now. And that puts a tremendous amount of pressure on EDs and hospitals. A couple of other things have happened. Hospitals are actually struggling right now to get patients discharged from the floors and from the units, as you mentioned. There aren't enough SNF beds to get patients moved to, and facilities are often very hesitant to take patients who have any kind of behavioral problem. And so these patients languish on hospital floors, sometimes for weeks at a time, before we can get them out.
And are there new requirements for hospitals on discharge protections? Like, are there things where they're having to verify that there's, some sort of continuity of care on the other side that's slowing it down?
Well, especially with patients who are unhoused, we are now required to provide them with services, social services, to get them safely discharged so that we're not just, tossing somebody out into the street who perhaps needs access to a shelter or some other facility. And this can greatly extend the time that the patient spends in the hospital or in the emergency department.
So it's not, I guess, what's the ratio here? I mean, is it mostly a bottleneck on the larger hospital and discharge that slows down the throughput of the ED and treating, discharging patients that don't need to be admitted? How does that interplay work?
So again, it depends on the hospital, and it's very different from one hospital to another. Some emergency departments have developed tremendous efficiencies in being able to improve the throughput of patients who don't require admission. Where I work, we actually placed a physician in the lobby, in the waiting room, who can see all the patients who come in with sore throats and earaches and cough and, ankle pain, who maybe they just need an exam or a chest x-ray or an ankle x-ray. And those patients can be discharged without ever actually getting into a bed in the main ED. And that tremendously offloads the main ED and the utilization of beds to allow for more, complicated patients to occupy those beds. In addition, at times when we're really surging, we have the ability to move staff around and open up non-traditional parts of the hospital. We have what had originally been planned to be a waiting room for patients waiting for a ride home called the Transportation Lounge that we have now made into an 8-bed treatment area during times of surge or when we're boarding large amounts of patients in the emergency department. So there are a number of strategies that EDs follow in order to mitigate the patient load. And we can talk about some of those later. There are actually quite a few of them. But the other issue that we're seeing is that patients are, we criticize patients for coming to the emergency department when they perhaps should have seen their primary care physician. But what a lot of people don't realize is that often patients have called their primary care physician and been directed to the emergency department because most primary care physician offices don't have sophisticated laboratory availability, sophisticated imaging, and also are as risk averse as anyone else. So when you call your physician's office, if you say the word chest and pain in the same paragraph, they're going to send you to the emergency department. It's the rare patient that will get an appointment necessarily for anything even approaching acute problems with their primary care physician.
Yeah. And do you see, similar with urgent cares, right? And risk aversion where they're saying, hey, we think like 95% certainty that this is not going to be something serious, but you might want to get that, or we want you to have that CT, right? We want you to have that reassuring thing. So please head to Stanford Emergency Department to go get that done.
That is also an issue. And I have to say that I'm not 100% sold on the concept of urgent care. It feels to me sometimes like it's just increasing the footprint of the healthcare system and the cost while actually really deteriorating the efficiency, because we have a very, very large number of patients who are coming to us from urgent care centers. And the whole paradigm of urgent care centers revolves around expecting patients to be able to self-triage into the level of the care they need. And patients really aren't educated to do that. we rely upon very, very experienced and very well-educated triage nurses to be able to make those decisions. And even they sometimes get it wrong.
So I think an interesting thing too, because I know we're going to have more discussion around strategies and like at the macro level, what are the discussions around system change and things that can help kind of free up the, the pre-hospital and increase, flow or at least how more coordination can make those moments more bearable for the people involved in it. And also, more productive and getting back to some sort of baseline, right? But maybe we could focus in on like an actual moment where this is occurring, like at a hospital, right? And talk about the effects both on the hospital side and also on the pre-hospital system. So let's say at Stanford, it is a particularly busy day in the community, right? Not just the hospital. And what starts to happen, right? Like what's the, let's start with the pre-hospital side. Let's say that the ambulances start stacking up in the emergency department and cannot be released because there's nowhere to offload them and no resources to assume care. What starts to happen to the San Jose Fire Department?
Well, so San Jose Fire Department, just as a point.
Or sorry, not San Jose Fire Department.
Palo Alto Fire Department.
Palo Alto Fire Department.
And the county EMS
I'm mixing
agency.
cities.
So what's interesting is that we don't actually ever hold ambulances. And we often are boarding at least half, if not more, of our emergency department beds are occupied by inpatients. What we do in those situations is many of the ambulance patients are sent to the waiting room, because just because you arrived by ambulance doesn't mean that you have a higher priority medical complaint than somebody who came in by private vehicle. We have STEMIs come in by private vehicle, strokes come in by private vehicle, and thumb injuries that come in by ambulance. And so when the ambulance calls into the resource nurse, when they give report, a decision is made whether or not that patient needs an immediate bed or whether or not they can go to the waiting room. And a very large percentage of them, most of them often go to the waiting room. When they can't, in an emergency department the size of Stanford, we are either discharging or admitting a patient. I was told by the nurse manager, on average, about every 4 to 5 minutes. And when you have that kind of turnover, then you can't justify holding an ambulance for hours at a time, waiting for a bed to open up. That means that there are no patients moving at all in your institution. Nobody's being discharged from the ED. Nobody's being admitted up into the inpatient units. And this holds even when we're boarding more than half the ED. When we're boarding a large number of patients in the emergency department, we do take over basically what we call surge spaces, which are areas of the hospital that aren't traditionally part of the emergency department, but can be set up with cots and folding screens and, be used as treatment areas with, varying acuity depending on, how much monitoring equipment we can set up there and all that. But when you are using your staff and using your space with a good deal of flexibility, then you're able to adjust to meet the demand as needed. We don't break our patient ratios, that's a state law, but there is an attitude of just pulling together and getting it done that is especially prevalent among the nurses. If anything, sometimes the nurses are pushing the physicians, to see more patients and to get more patients into treatment spaces.
That's really interesting. So the ED inpatient, having the patients inpatient or having the patients as an inpatient admitted status in the ED can, are you saying can break down some of the cross-department challenges or maybe attitudes of like getting it done or boarding patients or dealing with all of that?
Yeah, one of the things that they'll do is they'll get activate if an entire pod is filled with inpatients, which is quite frequently the case. The team assigned to that pod will simply move elsewhere. And so I've come in, for instance, to work a shift in what we call our Delta pod, one of our main, emergency department pods, and found the entire pod is filled with inpatients. And so I moved to the transportation lounge, and my entire shift with the residents and the nurses and the techs is all spent in the transportation lounge. And that's where we see our patients. We have set up in our emergency department 2 vertical zones of 8 beds each, and taken over the triage rooms And so when I'm working as a shift in one of those zones, all of my patients are in chairs set up in temporary, screened areas in corners of the waiting room. They've simply taken temporary walls and put them up around kind of lounge chairs that we've all seen in hospitals. And for patients who don't need to be on a stretcher itself, they wait in those chairs. They're brought into the triage room for an exam because those triage rooms are private exam rooms. I can interview them in privacy. I can examine them in privacy. And then they order whatever tests, MRI, CT scan, labs. They go back to the chair and I bring the next patient in. And then, when we're ready to either admit or discharge, then that process occurs in reverse. And that's increased our capacity in the emergency department by 16 beds. And when you see patients in that manner, it makes the emergency physician very, very efficient. I can see, I'm not sitting around waiting for beds to open up to see patients. I'm the rate limiting step. And when I'm the most expensive resource in the emergency department. And so you want the physician to be the rate limiting step. You don't want the bottlenecks to occur elsewhere.
Yeah. And one of the first places where I saw this done, or at least, in my experience, not saying they were the first, but Community Regional Medical Center in Fresno is a very high volume. And essentially it's the only trauma center for the Central Valley area. Mm-hmm. But it's just it's the non-diversion hospital, that will not stop receiving patients and will always receive, ambulances. They were doing that also. They essentially, I don't want to call it a mass casualty, but a large patient treatment out of the emergency department where the first person you'd speak to is a physician. So the physician could chart, what course of care you needed, what labs, assessments. You go back to their waiting room seat, and then they would proceed with that process, bringing you back to get the EKG, back to the waiting room, bring you in to get labs, back to the waiting room. And it dramatically improved. I think it also improved the system efficiency, but I think it can also improve patient satisfaction, right? Because the first person they're talking to is a physician, and they're getting answers and they're getting action,
Yes. Well, and we do something similar. We do have a triage physician, but they don't see every patient. Their mandate is really to see those very low acuity patients that can be discharged without ever going into the emergency department. We do have nursing protocol orders so that when a patient presents and gets triaged, the nurses can, based on the chief complaint, execute certain labs and tests based on preset protocols. And so what that means is that their bloods are drawn. And even when we have long waits, when I'm working down in the front of the emergency department in the higher acuity area, in the area that actually has beds, oftentimes patients, by the time they get to me, all their labs have resulted. Their x-ray has been done. And all I need to do is actually do the history and physical and maybe get a second troponin, or I can often disposition the patient almost immediately after I've seen them. So that is just another, method of increasing the efficiency of the emergency department. Some criticize it because it can lead to unnecessary labs sometimes. But when you're in a situation where you're just trying to deal with an enormous volume and use your space as efficiently as possible, I think that paying for that with a slightly decreased efficiency in lab utilization is pretty reasonable.
So let's switch to maybe the pre-hospital space a little bit.
Yeah.
What are systems doing on their side, right? What's their reaction when these moments happen where they have found, or at least trying different strategies to improve the 911 efficiency or handle these scenarios where they, they're doing their normal responses, they're transporting, but they can't free up those units, right? They're at the end of their call and they can't get back in service.
So for the pre-hospital community, it's exceedingly frustrating because the ability to surge EMS units doesn't exist the way, hospitals can sometimes surge capacity by moving resources or adding resources. So what happens is that you simply start running out of ambulances. The ambulances that are holding the wall are not available to the system. And as Sacramento recently demonstrated, this can result in incredibly long response times to very, very high acuity calls. What does happen in some instances is that fire suppression resources, engine companies and truck companies, are dispatched as first responders to these calls. and they assume care of the patient while waiting for an ambulance to arrive. But then they're not available either for another medical call or for a fire call. And especially in California, where getting resources onto a fire is incredibly important, as we saw, recently in LA County, having those resources delayed can result in a 1-alarm fire going to a 2 or a 3-alarm fire, and can result in, somebody who's having difficulty evacuating the fire ending up being a fire fatality because those resources were sitting at a medical call unavailable to respond. What some ambulance services have done too is assigned an EMT to watch a number of patients after, so that those ambulances can be freed up. But again, that's the EMS system fixing a hospital problem. And the problem is just starting to become self-fulfilling, as we have seen an enormous reduction in the number of paramedics in the workforce, because no paramedic wants to come to work, go on a 911 call, and then sit on the wall for the better part of the remainder of their shift. And so we're not keeping paramedics in the system. We're not attracting new paramedics into the system because working has just become painful.
Yeah, it's definitely counter to the intended experience or work experience, right, for these providers. And I think that is perhaps one of the most frustrating things. Certainly, my experience is pre-hospital, is the inability to make a change, right?
Yeah.
There's nothing to be done in that space. So I have some questions for you.
Yeah.
About some legal. I'm not a lawyer.
Neither am I.
But I do have some questions around legality around this. And you hit on one that I had a question on outright. Are there any, I know there are mechanisms to downgrade a patient, but from a medical director perspective, what are the challenges with downgrading a patient that's received ALS care, and also changing the ratio when you assign them to an EMT that is, again, maintaining all the documentation of their vitals, right, until the transition of care? You're essentially stopping any treatment, or maybe you have provided treatment. Are those handled in the protocols, like would be mirroring a pre-hospital downgrade? How does that work?
So, that's one, certainly one of the legal challenges is, taking an ALS patient and then saying, well, they don't actually need ALS anymore. Each EMS agency and each service needs to develop its protocols in determining, okay, when does that ability to transition from ALS to BLS occur? I think it's very reasonable that if a patient gets a single dose of, for instance, pain medication for a fracture and they're monitored for 20 minutes, yeah, that patient probably doesn't need ALS anymore. But if you have a patient on a monitor, then it's awfully hard to justify saying, well, they don't need the monitor anymore. Then they don't need a monitored bed, and they should be able to actually just go to the waiting room. So I think there are challenges there. I don't think we have an awful lot of case law on that yet, but I can smell it a-coming. The other big legal challenge certainly revolves around EMTALA. And the Emergency Medical Treatment and Labor Act is designed to prevent emergency departments from refusing to see patients who are brought by ambulance. It stems out of cases back in the 70s and 80s where patients who were either underinsured or uninsured would simply not be allowed into a hospital. And the ambulance would be told, oh, take them elsewhere. And that resulted in some bad outcomes. And that's where the Emergency Medical Treatment and Labor Act came from. Hospitals are required to accept all ambulance patients. They're required to do a medical screening exam, and they're required to stabilize the patient. Now, there is opinion out there in the legal community that wall time by definition is an EMTALA violation because the patients are actually on the ambulance, on the hospital property rather. The State Department of Public Health, CDPH, has put out the opinion that it is not an EMTALA violation because the EMTALA law doesn't set a specific time by which the hospital has to accept an ambulance patient. What's interesting, though, is that it also doesn't set a specific handoff that has to occur between the ambulance and the hospital. And so there's also opinion out there that the paramedics could simply give verbal report to the triage nurse, and whether they accept the patient or not, drop them off in the waiting room. That hasn't happened very much yet. I think it's also coming, but I've heard also that ambulance services are considering suing hospitals for utilizing their services without paying for it. They're essentially shanghaiing EMTs and paramedics into taking care of patients on their hospital property.
So a couple follow-up questions. On one, you mentioned dropping patients off in emergency departments. I have worked in systems where that was an agreement between the hospital and the pre-hospital staff or the pre-hospital system that patients that were, assessed by a paramedic that had an appropriate physical assessment and review of any needed care items. And if they didn't need any care by the criteria of pre-hospital guidelines and, opinion, that they could be brought to the emergency department, that there could be a verbal report given and that patient would wait in the emergency room. That's great if that's able to be established in collaboration and coordination, but what's the legality for an ambulance service or fire department saying, we're just going to put them in your emergency department because you're not accepting them?
That's going to depend on case law, frankly. If there's a bad outcome, obviously if a critically ill patient is brought in and the ambulance simply drops them off and leaves, that's not going to go well for any EMS agency. If it's a very low acuity patient and they simply have a poor outcome or they leave as a consequence of not wanting to wait in the waiting room any longer, case law is going to kind of determine how that goes. One category of patients that is problematic and accounts for a fairly significant portion of wall time are mental health patients and patients on 5150 holds. People have to remember that 5150 holds can either be placed by law enforcement or by a physician in the hospital. They are not able to be placed or enforced by EMTs or paramedics. And so a patient who is brought to the emergency department on a 5150 hold, if they decide to leave, the paramedics have no authority to keep them there. And so the hospital is, I think, playing with fire if they have a patient who is known to be on a 5150 hold and they're not taking steps to make that patient safe and prevent them from potentially leaving or harming themselves and relying on EMS to do that for them. EMS cannot do that for them.
One last question I have around this, which I feel will resonate with a lot of pre-hospital providers. A couple questions, maybe starting with, are paramedics allowed to practice in hospitals in California?
It's a great question. And it's not been thoroughly settled. A reading of state law would suggest that no, their authority to practice does not extend within the hospital. However, again, the state EMS agency in some counties have reinterpreted that to suggest that with county LEMSA authority, they can. Again, hard to say how that would hold up in a court. But when, at least my reading of state law suggests that it's a fairly liberal interpretation to suggest that they can. And I guess the paramedic and the LEMSA who do allow that, if there is an issue, I think the accountability is going to be determined in court.
And so kind of a follow-up to that is, in this transition of care moment, I think it can feel very problematic to pre-hospital providers, right? You've provided care in the pre-hospital space, and now you're in this transitory kind of space, waiting for a bed, right? You're no longer in the field. You've already given, a radio report, perhaps even like a verbal report to a charge nurse, right? They're trying to place them. Is the paramedic, I think by EMTALA definitions, you're already on hospital grounds, right?
Mm-hmm.
But you're not an employee of the hospital. You're not authorized by the hospital to do anything, right? It's a very interesting scenario.
Yeah.
So
and I've seen,
maybe, go ahead.
What's interesting is I've heard medical control tapes, recordings there where a paramedic has a patient in a hospital waiting for a bed who is deteriorating. Their blood pressure is deteriorating. And the hospital in which they are located is not accepting the patient, is not accepting responsibility for the patient. And so the paramedic is having to call for medical control from a different hospital for a patient that is already within the walls of one hospital. And that to me is that's crazy.
Well, so a follow-up to that, right? Let's say that I start care, right? And I'm following my protocol. Let's say it's a chest pain call, just kind of the run-of-the-mill chest pain call. Can't rule cardiac origin out, right? but it's not a STEMI. They seem relatively stable. I'm providing potentially, nitro every 5 minutes. I've given aspirin. I have an IV established, all these things. As a paramedic, am I to continue that treatment? If I'm holding, if they've deemed the patient non-urgent, but my protocol says that I'm to deliver this care, do I continue to give nitro every 5 minutes for 2 hours? Like it's an interesting.
That's a great question. And quite frankly, that's a situation in which base station control is probably appropriate. At the end of the day, we have to do what's safest and best for the patient. And rigidly following a protocol in a situation that the protocol wasn't designed for isn't necessarily going to be the best thing for the patient. And so in a situation like that, I'd be contacting the base physician and, saying, hey, look, we've given like 3 or 4 or 5 nitro. It's not making a dent. The patient's ECG isn't changing. The base station physician may, either say, look, either, keep it up as long as the blood pressure's up, or probably more likely, let's hold off on that since it doesn't seem to be having an effect.
Which is interesting because it's the same scenario you're discussing, though. Now you have a base physician from potentially another facility giving direction.
That's the way the systems are designed. And it seems crazy and odd, but that's the way the system is currently designed. The system was never designed to deal with extended wall times inside of hospitals.
I guess one last question on this. What are your thoughts on care being started hospital care being started while the hospital has not assumed care by placing that patient somewhere?
So as soon as the patient, any hospital says we haven't assumed care, but has started treatment, has assumed care. What furniture the patient is on is not relevant. And I think no court in the world would say, no, you're right, that's not your patient, even though you started giving medications and drawing blood and doing imaging. Since they were on the ambulance stretcher, it's still the ambulance's patient. Now, once you actually, as soon as somebody makes contact with that patient from the hospital, it's their patient.
So this is that fuzzy space, though. You have a patient that hasn't been assigned to a nurse under California ratios, et cetera, all the considerations there.
Mm-hmm.
But you have a physician potentially ordering labs or doing other things while an ambulance service that is no longer recovering any revenue for the longer time is supervising the patient and monitoring them, gets into a very fuzzy space quickly.
Yeah, and that's frankly mostly going to be on the physician and the hospital because, physicians can't authorize expanded scope of practice to paramedics on the fly. And so if they are initiating treatment, then it's their responsibility to monitor that treatment. And I can't see any situation, and again, I'm not a lawyer, but I can't see any situation in which any reasonable court would not say, once you've seen the patient and started care, they're your patient. It's, EMS is no longer their caregiver.
Which could lead to other cases where, like you mentioned, transferring costs to people or doing to organizations would be a immediate follow-on to that, right?
Absolutely.
So pulling back a little bit, maybe to the state level, because you sit on the California EMS Commission,
Mm-hmm.
You've been in other leadership roles with NMSP. Who are the stakeholders that are working on this at a larger level? I mean, we've clearly discussed that there's an obvious community approach, hospital approach, right, to handle these different variables and what can be accomplished. And there's a lot of strategies that the hospitals can try to implement or are implementing with good success to try to improve these moments. What is happening at the state level? What is the discussion? What's that room like? What's going on in there?
So
what are people talking about?
So it's interesting. So, as you mentioned, AB 40 was passed back in 2023. And for any of the listeners who don't know the legislative and regulatory process, once a law like that is passed, then it gets assigned to an agency of the state government to generate regulation surrounding that law. The implementation of the law has to be done through regulation. And in this case, the EMS authority, the state EMS authority, has to generate regulation. Those regulations are put through public review through stakeholders, and stakeholders get to comment on the regulations, in which case they might be adjusted until there has been sufficient input and it is felt that they're ready for publication. Now, what's interesting is that they withdrew the regulation package for AB 40 on April 14th after it had been submitted to the Office of Administrative Law for review. So I'm not quite sure what that means. I'm sure I'll find out when I ask that question at the next commission meeting in June. But at this point, coming up on to, a year and a half since AB 40 was signed by the governor, we don't have any enabling regulations enforcing it. And if you read AB 40, it's not clear that it has a tremendous amount of teeth. There's no penalty for failing to meet the 30-minute offload time. And the offload time is determined once a nurse has signed a transfer of care. And it's not clear to me that they would be able to get around this by just simply not being available to sign, give this electronic signature. So I'm not sure how much effect AB 40 is going to have. I think that what is going to be more effective is agencies, EMS agencies, and their hospitals working together. I know Sacramento has had tremendous success in reducing offload delays after they presented in one case, they presented an actual call that had occurred during a time when a number of ambulances were on wall time and showed how far away the nearest available unit was to answer this high priority call. And that turned out to be very, very eye-opening to the nurse administrators and the hospital administrators to recognize that this was in fact a problem. It's very easy when, we in the emergency department have always been frustrated when the inpatient units don't seem to see how many patients we're holding in the ED and how many patients we're boarding because, they're not down there. They don't see them. They don't see how crowded the waiting room has become as a result. In a similar way, when a community's ambulance resources are all parked in emergency departments, the ED doesn't see what's going on out in the community. They don't see the calls lining up, the queue in the 911 system, and patients who are waiting for ambulances out in their homes or out on the street. Sometimes in the area around here, sometimes for longer than 30, 40, 45 minutes for high priority calls.
So getting to see this from your hospital level perspective or your hospital role on the EMS Commission, maybe I'll ask it, maybe it's unanswerable in this moment, but I'm curious to get your thoughts on it. And I'm sure our listeners are as well. What do you think the resolution pathway will be here long term? Is it going to be something where it's the lobbying through the state to produce law? What sounds like an additional step of lobbying against regulation to get that kind of tuned in, and that will be the answer? Do you think it'll be clinical risk and financial risk through case law where something will bubble up out of something happening or a series of things happening for a long extended period of time? Just your perspective.
Yeah, it's a great question, and it's hard to predict how this is going to resolve. In order for it to have resolved in the hospitals that do a good job, that actually have little or no offload delays, it's a culture. It's how the culture of the emergency department and hospital work. It's a culture of everybody kind of stepping up to get the right thing done. And building a culture is very, very difficult and time consuming. In another kind of related area, when I was in Massachusetts back in 2009, I believe, the state of Massachusetts simply banned diversion. Diversion had become an issue where hospitals were on diversion all of the time. All the emergency departments were overcrowded. They would all go on diversion, and ambulances were basically left with almost nowhere to go. And finally, the state, after looking at the problem, realized that diversion was causing more problems than it was solving, and just straight out banned it altogether. The only time you could go in diversion is if your hospital was on fire, or the water main had broken or something like that. And the hospitals freaked out, and it was going to be a great big huge catastrophe. And then it went into effect and nothing happened. It made everything better. And a number of jurisdictions have banned ambulance diversion since then. Not very many on a statewide level, but what's interesting is in the Bay Area here, San Mateo County does not permit diversion. And that was actually an agreement from the nurse managers in the emergency departments who realized it was just causing problems. Patients were ending up in the wrong hospitals where their record didn't exist. And it wasn't actually making things better for busy emergency departments. Santa Clara County has not gone in that direction and continues to resist the idea of prohibiting diversion. And so, I think in some cases it will require some legislation with teeth. In some cases, culture change. And unfortunately, some of that may be triggered by a catastrophic outcome. And in a state as large as California, we know we've already had some bad outcomes. What, may happen is that one of them becomes a big public media frenzy. And in that case, a lot of people are going to be put on, held to account as to why the system allowed this catastrophic outcome to occur.
Well, it's definitely an evolving topic. I appreciate all your perspective on this. I know that we're co-hosts of this show together, but it was a joy interviewing about this and learning more. And you're just uniquely positioned to comment on this from a lot of different directions. So I know we'll probably have more guests on about this and talk about this in future episodes, just because it's such an important topic to system operations and our community's well-being and how things run. So thank you, Marc. And
absolutely. And I am really looking forward to talking about some of the really innovative solutions in the next hit on this topic.
Yeah. And I'd love to hear from some of the, yourself and some of the team members at those institutions that are doing those things. It'd be really cool.
Absolutely.
Thank you all for listening to the Shreds of Evidence podcast, dedicated to exploring the science and politics of EMS practice in California. This podcast has been made possible by a grant from the Bill and Christy Natick Foundation, as well as the California Paramedic Foundation and the Department of Emergency Medicine at Stanford University.